Hi, dear colleagues. I'm pleased to participate in this conference dedicated to the memory of Professor Constantin Danilyan, as he was one of my best teachers and made a great contribution to my professional work. So today I'm going to present gender identity disorders in youth. First, I would like to describe it as according to the DSM-4. The DSM-4 describes gender identity disorder as a persistent and strong cross-gender identification and a persistent unease with one's sex, not just seeking any perceived cultural benefits of being a different gender. Gender identity disorder is not diagnosed if these symptoms co-occur with a physical intersex condition. As with the sexual disorders, a diagnosis is only made if the symptoms produce marked distress or impairment. According to DSM-4, gender identity disorder can occur in childhood, adolescence, and adulthood. Gender dysphoria is the new term for gender identity disorder. In order to prevent stigma, guarantee clinical care for people who perceive and believe that they are a different sex than their designated gender. Some people who are transgender will experience gender dysphoria, which refers to psychological distress that results from an incongruence between one's sex assigned at birth and one's gender identity. Though gender dysphoria often begins in childhood, some people may not experience it until after puberty or much later. It is important to note that gender identity is different from gender expression, whereas gender identity refers to one's psychological sense of their gender. Gender expression refers to the way in which one presents to the world in a gendered way. For example, in many countries, wearing a dress is considered a feminine gender expression, and wearing, for example, smoking is considered a masculine gender expression. Such expectations are culturally defined and vary across time and culture. One's gender expression doesn't necessarily align with their gender identity. Diverse gender expressions, much like diverse gender identities, are not indications of gender identity disorder. As you see in my slide, you see men wearing dress and women wearing smoking. It doesn't mean that they are transgenders. Epidemiology, according to the DSM-5, the prevalence of gender dysphoria is 0.005 to 0.014 for adult natal males and 0.002 to 0.003% for adult natal females. In Europe, 1 per 30,000 adult males and 1 per 100,000 adult females seek sexual reassignment surgery. Among children, it is higher in those born as boys, where it is 2 to 4.5 times greater than those born as girls. Among teenagers, there is no real difference between males and females. Diagnosis of gender identity disorders, according to DSM-5, defines gender dysphoria in adolescents and adults as a marked incongruence between one's experienced expressed gender and their assigned gender lasting at least 6 months, as manifested by at least two of following criteria. First criteria is a marked incongruence between one's experienced expressed gender and primary and or secondary sex characteristics. Next one, a strong desire to be rid of one's primary and or secondary sex characteristics because of a marked incongruence with one's experienced expressed gender. A strong desire for the primary and or secondary sex characteristics of the other gender. Next one, a strong desire to be of the other gender or some alternative gender different from one's assigned gender. a strong desire to be treated as the other gender or some alternative gender different from one's assigned gender. And the last one, a strong conviction that one has the typical feelings and reactions of the other gender or some alternative gender different from one's assigned gender. In order to meet criteria for the diagnosis, the condition must also be associated with clinically significant distress or impairment in social, occupational, or other important areas of functioning. Also about comorbidities, gender identity disorder. It is associated with poor mental health and quality of life outcomes. Gender identity disorders has a negative impact on quality of life measures in adolescents and adult transgender populations compared with cisgender populations. Being transgender and in adolescence is associated with high rates of anxiety, self-harming behavior, and suicidality, and lower levels of psychosocial functioning. And also those who reported moderate to severe rejection by their family were more likely to attempt suicide. Here is a group of medical conditions, not only medical, but some conditions that we must consider when diagnosing gender identity disorder, gender dysphoria. First one is a gender atypical adult. For girls, tomboys without gender identity disorder prefer functional and gender neutral clothing. By contrast, girls with gender identity disorder persistently refuse to wear feminine clothes and also reject gender neutral clothes. They feel like the opposite sex. For boys, the differential diagnosis must distinguish between those who don't conform to traditional masculine sex expectations but don't show extensive cross-gender identification and are not discontact with being male and those who have a conflict with their sexual identity. Next one is hermaphrodites. We a little bit spoke about that. The diagnosis of gender dysphoria excludes children with anatomical intersex. Next one is body dysmorphic disorder or body dysmorphia is a mental health condition where a person spends a lot of time worrying about flaws in their appearance. These flaws are often unnoticeable to others. Next one is transvestic disorder. Individuals with transvestic disorder don't typically report a desire to be the opposite gender. They also typically don't have a history of cross-gender behavior, only cross-dressing. And the last one, psychotic disorders. Gender dysphoria in patients with schizophrenia may be the result of delusional change in gender identity or occur independently of the psychotic process. Distinguishing these situations is not only a diagnostic problem, but also influences therapeutic decision making. Now I will present case report concerning a boy aged 18 years was brought by his mother to our clinic with the complaints that her son believes that he is a girl and behave as a girl. The alarmed mother, unable to correct her son, has come to the doctors who might cure him. On separate interviews, we came to know the following facts. There wasn't any history of mental illness, epilepsy, his suicide, or divorce in the family. The boy's mother was married at the age of 21 years with a man who used to stay away from home, very often on official duties. At the age of 22 years, the unexpected first baby, a boy, came, but the mother wasn't able to take proper care of him. At 24, the planned second baby, our case under report, was born. But as parents expected a girl, they started to dress as a girl him. And From age 3 onwards, he used to play with girls and would say that he was a girl and wanted to be a woman like his mother. At age 6, he was sent to school. His grumbling, crying, scratching, and insistence that he was a girl fell on deaf ears. Thus, he became sad and isolated. His school performance gradually became poor by age 10. His inner conviction that he was a girl didn't weaken. At age 14 years, secondary sexual characteristics of a male began to appear, which disturbed him, but he was rather more firmly convinced that he was a girl. A distant cousin, aged 70 years, became the model man of his life. He felt erotically attracted to that cousin. He stopped attending school and started to mimic girls at home. On examination, the boy was fine looking, intelligent, but feminine in his attitudes and gestures. Examination of testes, penis, and pubic hair revealed no abnormalities. Other physical, including neurological examination, were normal. A detailed psychiatric examination, including the mental status examination, didn't reveal any abnormality except sexual deviation, which centered around his fixed belief that he was a girl. A diagnosis of gender dysphoria was made, despite his mother's insistence that the boy undergo treatment to become a normal man. But the boy completely disagreed and remained convinced that God was wrong, that he should have been born a girl, that he would definitely undergo sex reassignment surgery and return to normal life. In this case, on the report, we find a disturbance of gender identity, gender role, erotic orientation, and cross-dressing in early years. The diagnosis of gender dysphoria in this case is essentially based on the inner experience of cross-gender identity. The boy's erotic attachment to his cousin, a boy of 70 years old, is an expression of his disturbed erotic orientation. But this has to be distinguished from a homosexual's preference for a sex partner having the same genitals. The homosexual has no doubt about his gender identity and acknowledges that he is erotically aroused by a person of the same sex. The transsexual, in contrast, has a gender identity reveal. The fact that the boy on the report couldn't live up to the standard of male gender role is natural. He who firmly believed himself to be a woman can hardly behave as a man according to the society's consensus for it. And appropriate criteria for diagnosing this case are first one, a marked incongruence between one's experience expressed gender and primary secondary sex characteristics. Next one, a strong desire to be rid of one's primary and or secondary sex characteristics because of a marked incongruence with one's experienced expressed gender. A strong desire for the primary and or secondary sex characteristics of the other gender, and a strong desire to be of the other gender or some alternative gender different from one's assigned gender. Also, for the patients with gender dysphoria presenting to the clinic with direct request for hormonal and surgical sex reassignment, no drug treatment has been shown to be effective in reducing cross-gender desires. When patients with gender dysphoria go to the clinic with severe dysphoria, and incredible sex reassignment is the best solution. Medical treatment of gender dysphoria might include hormone therapy, such as feminizing hormone therapy or masculinizing hormone therapy, surgery such as feminizing surgery or masculinizing surgery to change the chest, external genitalia, internal genitalia, facial features, and body contour, and also behavioral health treatment. It's very important to take into account criteria for hormonal and surgical treatment of gender dysphoria. Persistent, well-documented gender dysphoria. Next one, capacity to make a fully informed decision and consent to treatment. Legal age in a person's country, or if younger, following the standard of care for children and adolescents. If significant medical or moral concerns are present, they must be reasonable, well controlled. Sometimes this is criticism. There are some criticism that many clinics and mental health professionals were using the criteria loosely, and many patients and parents now are reporting irreversible damage. So it's too important to follow to this criteria for the treatment. I mean, carefully for avoiding such cases concerning to hyperdiagnosing of gender dysphoria. And finally, we know that people with gender dysphoria have higher rates of social anxiety disorder than the general population. According to the one of research, many transgender youths are verbally harassed, nearly 54%, and physically assaulted, 24% in society due to their transgender identity. This can be reason of social anxiety disorder, and cognitive behavioral therapy has been found to be an effective treatment of social anxiety disorder. Thus, traditional CBT methods must be modified to meet the realities and needs of each society, because it is important to take into account the social cultural characteristics of each society. Thank you for your attention. I hope you found it useful. Thank you.